It's my pleasure to welcome Dr. Kasturi, and she'll be speaking on fillers and how fillers are meant to be injected. We've been conducting this course for the last 5 years. So if there's any questions, we are happy to take those, please.
Thank you, Dr. Debraj, for having me in this session. This IC has been running for almost 3 to 4 years, I think. 5 years, and it's always a delight to be in this course. You learn so much about the aesthetics and about the facial aesthetics. So after the wonderful talk by Dr. Shilpa is coming, I'll be speaking on the aesthetic applications of the dermal fillers. No financial interest in any product of the presentation. We all know that facial aging is often associated with loss of some tissue, and secondly, we also see hypertrophy of the tissue. The loss we basically see in the malar region when we look to the periocular region, and hypertrophy is basically the orbital fat that we see the prolapse of the orbital fat. And because of this loss and hypertrophy, there are different classification regarding the different types of presentation in the periocular region, where the most simple one we call the type 1 is a hill, where you have the fat. Type 2 is a valley, the trough. So these are different classification that has come out, and this is what we follow based on the atrophy changes that we see in the periorbital region, or the bulging changes, or the laxity. So one of the most common indication for dermal filler for the ophthalmologist is the tear trough, and when we call it tear trough, it is basically a separation of the palpable part of the orbicularis muscle from the orbital part of the orbicularis muscle. So this is actually the tear trough. But many times I see the people, they think that this nasojugal fold that you can see in green, many of them, they think that this is the tear trough. So this is not the correct tear trough. This is basically when this muscle splits up and we get a deepening, and this is what we call the tear trough. So you should know what is a prominent tear trough, and I feel that there are multiple factors which account for the changes. One being the depth of the trough, the second being the hyper or the dyspigmentation, and because of this it gives an illusion of depth, and the third being the prolapse of the nasal fat, especially in situation where you see the nasal fat when they might come much anterior or posterior to the plane of the lacrimal crest. And the most important thing that other aesthetic changes that we see around the eye are the rhytidosis. So we need to manage the wrinkles, we need to manage the trough, we need to manage the hills. So considering all the three important components, we feel that this is not only changes in the skin, but also it occurs in the changes in the bone. And because of this soft tissue and the bony changes, we see the conversion of this positive vector that we have to the face, where the malar eminence lies much anterior to the plane of the corneal plane, and this gets converted into negative vector because of the detusion or resorption of the bone, and this is what we call a negative vector. So the whole positivity, the young look, changes into a little elderly look because of the differential, uneven and site specific bone changes that we see, where the pyramid becomes more of a squarish as we age, and also the topographic changes, and this leads to multiple periocular changes, which can be in the form of the ibex, it can be in the form of the malar mounds and a festoon, it can be in the form of a double convex deformity, that is you have both the mounds and the bags, it can be in the form of the horizontal laxity, it can be in the form of dermatogalassis, or it can be in the form of the tear trough and other wrinkle periocular changes. So what balances this hypertrophy and hypertrophy? It is the dermal filler. And there are different types of dermal filler. I have already mentioned the most common indication is the tear trough and the hills and the valley. So as I have already shown you the classification, one is hill, valley, hill, valley, hill, valley, hill, valley. Okay, so when you have an early hill like this, you need not go for a surgery. You can very well manage with the dermal filler. So I'll be sharing you some of the patients out here, but if you have a very prominence of the orbital fat, when you have a very big orbital fat and this plane is much anterior, like it's so prominent, that is anterior to the plane of the anterior lacrimal crest, so these are the situation where the filler will not work. You need to go for the surgery. So there are different techniques and different injection patterns, but what we follow is basically the retrograde injection, so that we don't do any vascular complication. We follow the fanning pattern and we follow the Greek pattern. So I'll just go fast into some of the patients, and you can go go by the injection, you can go by the cannula, and the best way I feel is to go by the cannula. And when we all started, we started injection, and this is also a very nice way where directly you can inject the small aliquots of this dermal filler into the tear trough, and you see changes on the table. You can see the right side I am injecting, as I am injecting along the periorbital rim in the region of the tear trough, which we say the classical 3 points, TT1, TT2, TT3, and you see there's concealing of the fat. Look to the left. The left, you can still see the trough, you can see the fat, but on the right side it has vanished. So you can see the results on the table, and also it can be done not only with this injection needle, it can also be done with a cannula. So this is one of the patient who comes to me. You can see she's a young lady with very prominent fat. So in her case, you can use a cannula. Advantage of a cannula is that you do not get the brew, you do not get any of those small vascular changes that we see, and you can have a very good effacement of the lid cheek junction, as you can see here. And this is, she can look at her fat, that is before the injection and after the injection. There's concealing of the fat and also much improvement of the tear trough. So there are different ways of doing. Sometimes I do with cannula, sometimes with needle, and a combination of both cannula and needle. Especially when you do laterally, I feel a little injection with the needle gives a much better correction. And these are some of the patient where you can see the change from a negative vector to a positive vector. Can you see this, how it has changes from a negative to a positive vector, and it gives a very good correction of concealing the fat along with the correction of the tear trough. And I want to mention that results are just immediate. If you really look to his, see, this is the injection. This is the only 1 point entry of the cannula, and look at the change. The bags out here, you almost see that it has gone off. So there are different ways and there are different indications. One of the common indication when initially we started doing blepharoplasty and we used to remove lots of the fat, what we used to see the periocular pigmentation, we used to see lots of prominence of the tear trough. Can you see this? It has become so prominent. So those post blepharoplasty augmentation with dermal filler, it really works good. As you can see here, it gives a good correction. It fills up the the area, and you can get the results immediately. I think I have got just minutes or second, that is. So I'm just going faster. This is before and after the surgical procedure, and these are some of the patients who had gone for early blepharoplasty. They're very happy in the initial 5 years, but after 5 years, you see, look at the skin, it looks so much wrinkled up. You can see so much of the prominence of the tear trough. So these patients really work good when you do a augmentation with filler post surgery, and the results are really very good, and you can fill up their tears and also you can conceal the fat. So these are some of the patients that I like to share. And along with the other indication besides the periocular region, this is also under the patient where you inject the filler. This is with the cannula. You can do a very good injection, very good effacement of the lid cheek junction, and this is a beautiful product. Sometimes in crow's feet, like there are patients with static lines who do not work well or even with injection botulinum toxin. So along with the toxin, if you can do little bit of myomodulation by injecting the dermal filler, you can really do very well. We use this for a facelift, but facelift, I just want to show this animation. This is a most important point where you inject on the zygoma, because this is the most important point which many of the plastic surgeon call this is a G point. So if you give a first injection there are different ways. Either you give a single bolus or 3 aliquots. You can find that it not only lifts the face, it opens up the eye and also gives some amount of the eyebrow lift. So there are different points to it where you can really ovalize the face, you can slim the face. As you can see, this lady, she looks much better after the 3rd injection, before and after the procedure. So there are different indications. And another indication which has become a very common for all of us, the nasolabial fold and the lips. It really gives a very good fill up. As you can see here, this is a short video. I'll finish it in 1 minute. This is a short video of the whole face filler where you can see the classical point in the zygoma I'm giving in the mid face region. Then I'll give in the preauricular region in order to lift the face further. This we call this are different ways. You can just call it a preauricular region, or you can call the CK4 point, whichever it is convenient. Not going much into details. It's a very big topic. And so then after doing this mid face, you can also go for the chin augmentation. We have got much better product now for the chin augmentation. Then also you can also make the chin much elongated and also smoothen out, and then you can also go for the correction of the lips. So there are different ways, but many a times you can see the lips, it really make a change. This I'll be showing it. This is before, during the procedure, where you can do with a needle, you can do with a cannula, and I usually prefer using the cannula. I feel that why the advantage of using a cannula is that it doesn't give any of the bruise, and also any of the vascular complication is much less, and you get a much correction, beautiful correction of the lips. It need not give too much of volume. What we want, we just need a smoothening of the lip, like it should look a fresh looking lip. So there, I'll just end it here. I'll not show any other video. So also it can be used for scar revision, and yesterday I was talking on multiple functional indication. It is used for rhinoplasty, which is known as a liquid implant for the rhinoplasty, where especially in those type of broken nose, you can just correct the deformity, and it really gives a beautiful correction. And these are some of the indication, the facial indication. Thank you very much for the patient hearing, and thank you, Debraj, for having me in this